Good afternoon, everyone, and I welcome you all to 109th session of e-NISCHIT. जैसे कि आप जानते हैं कि e-NISCHIT हमारा कोलैबोरेशन है टीबी और एचआईवी के बारे में आप लोगों को और जागरूक करना और हमारी कैपेसिटी बिल्डिंग करना हमारे एआरटी सेंटर्स पे। और यही हमारा एक एंडेवर है जो हमेशा पिछले 4 सालों से है एंड हम उम्मीद करते हैं हम उस पर खरे उतरते हैं। सो आई वेलकम यू ऑल and I welcome all the ART centers from Delhi, Uttar Pradesh, and West Bengal to joining us. I'm Dr. Ananya, Prabhu. I'm chest specialist at NITRD, and it's with pleasure I'll introduce my team to you. So हमारे साथ जो हमारे टीम के पैनल है वो शेयर इंडिया से हमें ज्वाइन करें डॉक्टर ज्योति जो कि हमें और मिस्टर राकेश जो कि हमें लॉजिस्टिक्स और इसमें हेल्प करते हैं। डॉक्टर ज्योति जो पूरा कोऑर्डिनेटर करती हैं, शी इज चीफ कोऑर्डिनेटर। और मेरे साथ हमारे साथ आज हैं हमारे जो केस प्रेजेंट करेंगी डॉक्टर पूजा। She's a medical officer at our own ART center, NITRD. Thank you, Pooja, for joining us and sharing your case with us. And we are very privileged कि आज हमारे जो हमारे साथ एक्सपर्ट हैं वो हमारे इंस्टीट्यूट के पीडियाट्रिशियन डॉक्टर आलोक यादव सर हैं। और आलोक यादव सर बहुत ही सीनियर, नमस्ते सर, थैंक यू फॉर ज्वाइनिंग। बहुत ही सीनियर चेस्ट और पीडियाट्रिशियन दोनों हैं और इनका बहुत सालों का एक्सपीरियंस है जिससे आज हम बहुत सारा हमें लाभ होने वाला है क्योंकि इनको इनके पास टीबी का भी इतने सालों का एक्सपीरियंस है और एज अ पीडियाट्रिशियन आल्सो। सो हम वी कुडंट हैव आस्क्ड फॉर अ बेटर एक्सपर्ट एंड वी आर वेरी प्रिविलेज्ड सर दैट यू जॉइंड अस। थैंक यू फॉर जॉइनिंग अस टुडे। सो एज आई सेड कि हमने हमारा एक्सपर्ट पीडियाट्रिशियन है तो जाहिर है हमारा केस भी आज एक CLHIV का केस है।
The case today is of a 10-year male child who was brought to our emergency department of NITRD on 25th of December 2023 at 10:30 p.m. So the parents of the patient were complaining of fever, which was an on and off mode, and this was not associated with any evening rise and was relieved by taking antipyretics. Then they complained of cough with expectoration, which was not associated with any seasonal or diurnal variation, and it was not associated with hemoptysis. Also, he was complaining of pain abdomen, which was dull aching in nature, and it was not associated with nausea and vomiting. He complained of loss of appetite and loss of weight, and he was saying that he is having trouble breathing. Then we took the history of the child. We asked about the family history, but we couldn't find anything significant at that time. But later, upon working the child, we came to know that he is HIV positive, and we also tested their parents who came out HIV positive after the testing of the child. Also, on prior asking the mother, she didn't reveal her TB status, but later we came to know that the mother also had TB in earlier stages. Then we went for the workup of the child. On general examinations, the vitals were as mentioned, like the pulse rate was 108 and BP was 102 upon 60 and SpO2 was 97% at room air. And the systemic examination revealed that the respiratory system was showing bilateral bronchial sounds. And then we went into the background of the disease. So the patient was apparently well. So since last 2 months, he's suffering from the same symptoms, had taken treatment in different private hospitals. So first of all, he was taken to Green Park Hospital in a private setup where he was showing a persistent increase in TLC count from 19th of December 2023 to 23 of December 2023. And then there was a sudden decrease in his hemoglobin level, which was 6 gram per DL on 19th of December 2023. Then it was corrected after treatment. It was corrected by 22nd of December 2024. Also, he was worked up for CECT imaging at that time, which revealed infective bronchiolitis with necrotic mediastinal lymphadenopathy and bilateral pleural effusion, which was more onto the left side compared to the right side, and it was suggestive of a tubercular etiology. Then the patient was dissatisfied by the treatment at the private hospital. The patient was brought to us at the NITRD where we did all the workup. And the workup, on the workup, we have mentioned the CBC on different consequent dates. You can see at the bottom of the page. The X-ray revealed miliary tuberculosis. Based on, we also checked the serology of the patient, which revealed that the patient was HIV positive. We took the serum through 3 tests and then confirmed the HIV status of the patient. The CD4 count of this patient was 95, and then we started him on ART along with ATT. So the regimen for ART which the patient is receiving currently is AL 600 300 half tablet with AL 6030 1 tab OD followed with DTG which is half tablet, meaning 50. We are giving him double dose of DTG, and he is currently on 4C plus 4E regimen of ATT, and we are nebulizing the child on A plus I and supporting him with B complex, iron and calcium supplement for now.
Your case, for bringing up this case. As I understand that in your experience, like this child came to you, he was 10 years old. It was not that it's 2 years or 3 years old. And when you asked, his parents were not on ART. You had to figure out whether
Yeah,
the parents were.
we did the index tracing for this patient.
Okay, so because that's very unlikely that maybe the parents were not disclosing it. So that's another topic and a big discussion there, because 10 years and the parents must be HIV positive for more than 10 years, and maybe they didn't confess. Maybe they didn't.
We
They
tried
were
on the
because
counseling sessions and we tried interrogating them, but none of them disclosed it. But due to our protocols, we checked both of the parents and both of them came out to be HIV positive. Now we are counseling them to take the ART medicines for now, but still they are not ready. We are trying our level best.
Okay, because even ATT she was hesitant in
Yeah, she's
right?
even now she's not ready to take the ART with ATT medicines. According to her, the child is completely fine. Is sitting, is talking, everything is normal for her.
So, yeah, right. So this case really reflects what the real challenge in treating the CLHIV is, that you have to first go through the layers of the psychological issues and stigma issues and people hiding and patient hiding, child hiding. And then if you don't know the real diagnosis, how do you treat it? So it is very difficult. It is very challenging to treat children, and CLHIV is another level. So I understand the challenges that you presented, that in HIV. I will read out to them that you find them difficult to diagnose, you find them difficult to access specimen because they have atypical and variable clinical presentation, and also because the sample or paucity of sample, they are mostly possibly microbiologically, they don't have much of a bacterial load in children, and then there's delayed presentation. And then you also said lack of skilled staff to obtain adequate and specific specimen like gastric aspirate, because they do not produce sputum so easily. Then difficulty in preparing the readiness of the child to accept multiple medicine tests, definitely. And the establishment of accurate diagnosis and case detection and contact tracing is not routine, which I said, because prima facie you don't really suspect HIV at least. So Lisa TB. So thank you for presenting this case to us.
Thank you, Dr. Pooja, for presenting this case. This is a very interesting case, and the child is right now admitted in our ward. Thank you, Dr. Ananya, for introducing. And right now, this case is presently in the ward. So I just want to introduce regarding the TB HIV situation in the pediatric population. So right now, if you see the global TB report of 2022, near about 10.6 million persons got the TB infection in 2022. Out of them, 1.3 million are death in 2022. By this slide, you can see कि जो mainly जो infection है वो below 5 year वाले childrens में these group of children are more infected by the TB diseases, और mortality भी इसी group में सबसे ज्यादा है. यदि मैं टीबी एचआईवी की बात करें तो टीबी एचआईवी में नियर अबाउट 2.5 2.7 लाख के आसपास केसेस नोटिफाइड हुए थे, जिसमें 67% केसेस में एचआईवी टेस्टिंग हुई है, जिसके अंदर 4.4% वाज फाउंड पॉजिटिव एंड 86% आर ऑन एआरटी ट्रीटमेंट. रिगार्डिंग दिस केस, जो ये केस की जो चीफ कंप्लेंट्स हैं, दैट इज फीवर. फीवर इज नॉन डॉक्यूमेंटेड, ऑन एंड ऑफ है, एसोसिएटेड विद इवनिंग राइज फ्रॉम लास्ट 2 months, cup with expectoration from last 2 months, pain abdomen है, dull aching pain है, not associated with nausea and vomiting from last 1 month, loss of appetite है, loss of weight है, shortness of breath है. Mainly जो complaints थी ये childs को near about 2 to 3 months before fever के साथ में present हुई थी. Later on child have cough, pain abdomen, loss of appetite and shortness of breath. Then we come regarding this case जो हमारी WHO की clinical staging है, ये केस जो है it comes under stage 3 to stage 4. जैसे stage 3 के अंदर है unexplained fever है, intermittent है, constant है and longer than 1 month. Secondly, lymph node tuberculosis and pulmonary tuberculosis. This comes under stage 3. Unexplained anemia है, जैसे बताया डॉक्टर पूजा ने, न्यूट्रोपीनिया है, chronic thrombocytopenia है. एंड स्टेज 4 में एक्स्ट्रा पल्मोनरी ट्यूबरक्लोसिस, जैसा कि उसके सीटी एब्डोमेन के अंदर पिक्चर, ठीक है. तो एचआईवी के अंदर सबसे मोस्ट कॉमन जो इन्फेक्शन है दैट इज ट्यूबरक्लोसिस. नियर अबाउट 57% केसेस is of tuberculosis in the HIV cases. And near about when the CD4 count decreases and comes near about 300 to 200, then the chances of the tuberculosis is more. You can see in another slide. So pulmonary and extrapulmonary TB is the most common opportunistic infection presented in PLHIV, followed by candidiasis and diarrhea. ये HIV TB interaction है, cascade है. If you see the interaction between the HIV and TB, तो व्हाट इज हैपनिंग के फर्स्ट जो है इन पर्टिकुलरली एड्स इम्यून सप्रेशन होता है. इम्यून सप्रेशन की वजह से डिक्रीज इंटरफेरोन गामा इन TH1 लिम्फोसाइट है, दैट causes mycobacterial tuberculosis disease. When the TB infection happens, macrophage cytokines is produced, interleukin 1 and TNF alpha. They promote the viral replication, and again the viral load increases into the blood. So tuberculosis is the most common opportunistic infection in HIV/AIDS patient. People living with HIV are 18 times more likely to develop active TB disease than people without HIV. Among TB infection, PLHIV, 3 to 10% of the person develop TB disease every year, and 40 to 50% death due to TB, either PTB or APTB in HIV patients. So what are the clinical presentation of the TB if any child, because the diagnosis of the TB in the children is somehow different from the adult, because क्या है कि sensitivity adults के comparatively बच्चों में कम होती है. बच्चों में symptom based diagnosis ज्यादा होती है. You have to identify the symptoms, कि बच्चे में symptoms क्या हैं. Adult तो बता सकता है fever है, cough है, लेकिन बच्चे नहीं बता सकते. तो you have to identify कि व्हाट आर द क्लिनिकल पिक्चर ऑफ द पीटीबी. जैसे परसिस्टेंट फीवर है उसको लगातार बच्चे को 2 वीक है विदाउट नोन कॉज. ये फीवर हमेशा यू हैव टू डॉक्यूमेंट द फीवर. फीवर इज ए वेरी गुड फ्रेंड आल्सो, बिकॉज ही कैन टेल यू के व्हाट इज गोइंग इनटू योर बॉडी. सो बट ये फीवर हमेशा यू हैव टू आइडेंटिफाई द फीवर. जनरली मदर्स या पेरेंट्स बोलते हैं कि फीवर है, बच्चा गर्म लग रहा है बच्चा, लेकिन हमेशा जो है वो उसको डॉक्यूमेंट करिएगा. इफ परसिस्टेंट फीवर फॉर greater than 2 week without a known cause, unremitting cough for greater than 2 week, weight loss, this is a very important thing. Weight loss है more than 5% body weight as compared to highest weight recording in last 3 months, और poor weight gain है in last 3 months despite adequate nutrition or failure of nutritional rehabilitation in children with SAM, and contact with the patient with any form of active TB disease in last 2 years. This is very important. एक contact history है, weight loss हो रहा है या not gaining weight है. Second, वो third is fever, and fourth is cough that is not improving by giving the medicine. यदि हम EPTB की इस केस में बात करें तो देखो इसके mediastinal lymph node are enlarged, chest pain था, respiratory distress था, pleural pericardial effusion, abdominal pain था, chronic diarrhea, vomiting. In the abdominal cough generally symptoms are abdominal pain है, distension है, diarrhea, vomiting both. Child can present either diarrhea or vomiting or both, and abdominal mass. Regarding the unremitting cough after that is not improving by the TB medication, the sensitivity of this unremitting cough as you seen in the picture, persistent cough, the sensitivity is near about 88% in the TB patient. So what is happening in the HIV cases when the immunosuppression early stage जो present है वो just like adult TB cases की तरह present होती है, post primary adult TB cases, and in the late phase it resembles like a primary TB cases. Sputum smear in the early phase is often positive and late phase is often negative. Chest X-ray में early phase is just like a adult phase, just like a, so you can find smear positive, cavitary and other lesions also. But in the late phase when the immune suppression is decreases, then this presentation is just like a typical presentation or lymph node enlargement. So what are the method by which you can identify the TB? जस्ट लाइक जैसे स्पुटम है, सेल्फ एक्सपेक्टोरेंट या इंड्यूस्ड स्पुटम है बच्चों में, अल्टरनेटिव सैंपल्स जैसे एडल्ट्स के कंपैरेटिवली हम बच्चों में क्या चीज हम एडिटिव इंफॉर्मेशन से डायग्नोस्टिक यील्ड फाइंड आउट कर सकते हैं, दैट इज गैस्ट्रिक एस्पिरेट, गैस्ट्रिक लवाज, नेजोफेरिंजियल एस्पिरेशंस हैं, एंड स्पेशलाइज्ड इन्वेस्टिगेशंस आर स्टूल, ब्रोंकोस्कोपी, बाल, ईवास एंड टिश्यू बायोप्सीज. These are other specialized investigations. And newer nowadays, WHO has also approved stool and oral swab for in the children. So, in NTP approved test right now in India is genotypic testing, just like a CBNet testing, chip-based testing is NET and LPA. These are the genotypic testing. And phenotypic testing, as you know, culture, that is BACTEC MGIT 960 results. Culture के जो it will take some time, near about after 42 days the results you can got the result to confirm the negative result. So it will take near about 42 days. Culture, but till now culture is the gold standard. So in the children's, what are the algorithm you have to follow regarding the intrathoracic TB? So persistent fever है, unremitting cough है, weight loss है, जैसे I had already told you. Pulmonary TB in last 2 months. So first we do to chest X-ray. If chest X-ray is highly suggestive, then we send for the induced sputum gastric aspirate for NET. If NET result was found positive, then these comes under microbiologically confirmed TB cases. NET also find out that this child is ref resistant or ref sensitive. So according to that, if ref resistance, then you follow the ref resistance protocol, and ref sensitive you just start the ATT. If NET was found positive, then you have to look for another site like a significant enlarged peripheral lymph node, and also consider for the repeat NET from another site to find out a better quality of specimen, just like a BAL sample. May seek review from the higher center. किसी भी सैंपल में you find NET positive, then they comes under the microbiologically confirmed TB cases. If NET was found negative in the repeat sample, you can consider these children's diagnosis probable TB cases. So if chest X-ray non-specific shadow and give course of appropriate antibiotics, persistent shadow if there, and if chest X-ray is normal, evaluate for the EPTB. HIV testing should be offered to all children diagnostic with TB. So these are the WHO approved respiratory sample for diagnosis of the TB: sputum expectorant, induced sputum, gastric aspirate, nasopharyngeal aspiration, and stool. So what are the advantage, disadvantage? Generally expectorant sputum is low cost non-invasive test होता है, but this is not feasible for the young children, because as you all know that it is very difficult to expectorate the children and give the sample of the sputum smear for examination. Induced sputum, that is non-invasive, but it required actually equipment, hypertonic saline solution for the nebulization. So chances of the aerosol generation is also more in this particular exercise. So it is also the risk for the healthcare worker. And caregiver acceptance is also moderate. And when we take the gastric aspirate sample, but this sample is feasible in young children, but it need a specialized technique to get the gastric aspirate sample, because it is an invasive procedure, high level of discomfort in the children, required fasting, at least 6-hour fasting, and consumer and trained people. And caregiver, generally parents are also not very willing to put the rice tube into the children, so acceptance is also poor. In the nasopharyngeal aspiration, feasible in young children, less invasive than gastric aspirate sample, but disadvantage is because it is also invasive, required equipment and trained person, and chances of aerosol generation is also more, and caregiver acceptance is moderate. Stool, that is a good sample collection method, and this is the non-invasive test required, but the processing is difficult regarding the laboratory sample, because if and it is also not approved right now by the NTP, but you have to wait for the bowel movement of the children, and also the children's, there is no schedule particularly for the sputum for the stool particularly. So you have to wait when the child will pass the stool. So, but the caregiver acceptance is good in this particular method. So what are the diagnostic accuracy of expert MTV, RIF, ultra and pediatric samples? So in the sputum sample expert MTV, the sensitivity is 65%, gastric aspirate has good sensitivity 73%, NPA 46%, stool 61, and stool in HIV positive patient is 70%, and specificity is near about 98 to 100%. And expert ultra sputum sensitivity is 73%, gastric aspirate has low sensitivity than sputum, nasopharyngeal aspiration is 46%, stool is 53%, and sensitivity is 97 to 98%. So this is the diagnostic yield in different investigations. If you see the smear microscopy, the yield you need to find out the results, you need to 1000 to 10,000 specimen. Sensitivity is also very poor, near about 50 to 30%. In culture, you need at least 10 to 100 bacterial load, and real time also take near about 4 to 6 weeks. Real time sensitivity is 82%. Liquid culture has minimum 10 bacilli for get the specimen results, and it will take near about 6 weeks of time, and sensitivity is 85%. Expert MTV case load of bacterial load is at least 131 to 112 bacilli. It will take, but is a very fast process. You can get the result within 2 hours. Sensitivity is 60 to 70% among the children. Expert MTV Ref Ultra, the limit of detection is 15 to 38 bacilli. Results is also you can find out within 2 hours, and sensitivity is 64 to 75%. TrueNet limited detection is near about 100 bacilli at least. Reality you can find out within 1 hour, but data is not much data is not available in the children. LAMP results limit of detection is 100 bacilli, and you can find out the reality also in 2 hours, but sensitivity is near about 84%. So, among the HIV, PLHIV cases, you have to identify each and every time when the patient is coming for the examination. You have to intensify case finding. What is the intensified case finding? Screening for sign and symptom of the TB, early diagnosis and treatment, prevention of the TB infection, and TPT therapy. So, in the intensified case finding, there is 4S symptoms screening. Among the adult and adolescent, you have to ask the cough, fever, weight loss, night sweats. Among the children, you each and every visit, so you have to ask the children: is there any cough, fever, poor weight gain, significant weight loss, and history of contact with TB cases? People living with HIV are approximately 90 times more likely to develop TB disease than without HIV. PLHIV should be offered TB and HIV diagnostic facility at one-stop services to reduce diagnostic delay. The sensitivity of 4S symptoms, 4S complex, as we discussed, is near about 83%, and specificity is 38%. CVNet is the frontline test to diagnose the TB among PLHIV. So, what are the algorithm we followed in the HIV infected children? If any HIV infected children is coming and you are suspecting the TB, pulmonary or extrapulmonary, you send for NAT plus chest X-ray. If NAT finds positive, microbiologically diagnosed TB cases. NAT negative, but X-ray suggestive of TB, clinically diagnosis TB cases. NAT negative and X-ray negative for TB, non-TB. Among the extrapulmonary sample, NAT culture positive sample from extrapulmonary site, that is extrapulmonary TB, cytology, histopathologically examination, and chest X-ray and other radiologically examination. These are suggesting of TB. Then this comes under the extrapulmonary TB cases. So, if the child has PTB or EPTB, so investigate for TB and other diseases. If there is TB, then treat for the TB. Non-TB, then follow up, assist, and consider IPT therapy. This is very important. And if there is no TB, then you have to give appropriate treatment and consider IPT. If no IPT is contraindicated. If IPT is contraindicated, then defer IPT. If IPT is not contraindicated, give IPT. Screen for TB regularly at each encounter with a health worker or a visit to health facility. So, if the presumptive TB is PLHIV group, EPTB, smear negative, not available, but X-ray is highly suggestive, vulnerable population, contact with DRTB cases. And all notified TB cases, here the cases who are not responding for the TB treatment. First investigation is NAT. If NAT you found rifampicin resistance detected or not detected. So if rifampicin resistance you not detected, then send for first line LPA to find out the INH resistance detected. This is the right now we are doing it into the first line of investigations if rifampicin resistance not found. But if simultaneously you can start the drug sensitive TB regimen and if first line LPA rifampicin resistance detected, start the H monopoly DRTB regimen. If isoniazid resistance detected, stop drug sensitive TB regimen and also send for the reflex testing of second line LPA, liquid culture DST for moxifloxacin, pyrazinamide, linezolid and clofazimine. If any additive resistance is detected, then you have to modify the isoniazid regimen. And in another group who are not responding, repeat NAT investigations you have to send for the repeat NAT investigation. If rifampicin resistance detected, then send for the simultaneously send the sample for liquid culture DST, first line LPA, second line LPA, liquid culture DST, pyrazinamide, bedaquiline, clofazimine, moxifloxacin, linezolid, and delamanine. After pre-treatment evaluation, if no additive resistance detected or H resistance detected, CATG and INH mutation is not found, then these are eligible for the shorter oral bedaquiline regimen. If CATG and INH mutation is found, then these patients you have to start for the longer orally. This is a very important slide. In the children, if you didn't find out the sample, most of the time in the children you cannot find out the sample. So what approach you have to follow? So if children's TB patient had drug sensitive drug resistance status, if you find out the drug sensitive drug resistance status, then if drug sensitive, start the drug sensitive regimen. If drug resistance, start the drug resistance regimen. But if you didn't find out the sample, what is the status of the children, then see the child in the family, the child is the contact of any tuberculosis patient. What is the status of that particular tuberculosis patient? If the source patient is drug resistance patient, consult pediatrician, try to reattempt the drug sensitive treatment of a appropriate regimen from the child, even if required, investigate like BAL. If still no information on resistance pattern, retreatment according to DST of the source cases. Basically, उस बच्चे में you have to try to reattempt the sample. If you didn't find out the sample, तो जो उसका contact है, उसके accordingly you can start the drug resistant regimen. इन द सेकंड सिनेरियो इफ सोर्स पेशेंट नॉट नोन या सोर्स पेशेंट का भी कोई स्टेटस नहीं है तो चाइल्ड और सोर्स पेशेंट दोनों में हम इन्वेस्टिगेट कराते हैं यदि हमें चाइल्ड में पता चल गया तो अकॉर्डिंग टू दैट वी कैन ट्रीट द चाइल्ड इफ सोर्स पेशेंट में हमें पता चला दैट इज ड्रग सेंसिटिव एंड ड्रग रेजिस्टेंस तो यू कैन ट्रीट द चाइल्ड अकॉर्डिंग टू द पैटर्न so these are the doses among the children as you all know that जो children's की जो tablet हैं आजकल वो FDC based tablets आ रही हैं and weight regimen के accordingly आ रही हैं in this slide जो weight band है that is divided into 4 to 7 8 to 11 12 to 15 16 to 24 25 to 39 and 30 to 39 so these are the intensive phase you all know and this is the continuation phase as in the intensive phase you give HRZ and in the continuation phase you give basically ethambutol is given separately to the children and this is the daily dosage regimen isoniazid 10 to 15 milligram rifampicin 10 to 20 ethambutol 15 to 25 pyrazinamide and 30 to 40 सो ट्रीटमेंट रेजिमेंट क्या है पीडियाट्रिक्स के अंदर न्यू एंड प्रीवियसली ट्रीटेड के अंदर ट्रीटमेंट रेजिमेंट है 2 HRZ टोटल 56 डोजेज एंड 4 HRE इन द DRTB के अंदर H मोनो के अंदर 6 मंथ ऑफ लिवोफ्लॉक्सासिन REZ है इन द ड्रग रेजिस्टेंस केसेस ओरल बेडाक्विलिन कॉन्टैक्ट रेजिमेंट में 4 to 6 मंथ ऑफ बेडाक्विलिन लिवोफ्लॉक्सासिन क्लोफाजमिन पायराजिनामाइड ethambutol hydrose INH and ethionamide and 5 months of levofloxacin clofazimine pyrazinamide and ethambutol shorter injectable regimen second is in this regimen We are using moxifloxacin, amikacin, kanamycin, ethionamide, clofazimine, pyrazinamide, hydroj, INH, and ethambutol. In 5 months of moxifloxacin, clofazimine, pyrazinamide, and ethambutol. In the MDR cases, longer oral MDR regimen is 18 to 20 months of levofloxacin, 6 months of bedaquiline, linezolid, clofazimine, and cyclosporine. And in this slide, as you see that the severity of the disease, right now you have to in which type of patient you are starting the shorter regimen, and which type of patient you are starting the all oral longer regimen, is also decided by the severity of the disease. If non-severe TB cases के अंदर इंट्राथोरेसिक lymph node TB without airway compression, uncomplicated pleural effusion है, paucivacillary non-cavitary disease, this comes under non-severe TB disease. Extensive TB disease के अंदर आता है presence of bilateral cavitary disease or extensive parenchymal damage on chest X-ray in children age 15 year, presence of cavitary or bilateral disease in chest region. These are the extensive diseases. Severe EPTB के अंदर presence of miliary TB, TB meningitis, CNS TB, TB spine, abdominal TB in children age under 15 year, extrapulmonary form of disease other than lymphadenopathy. 15 साल से छोटे बच्चे में कोई भी extrapulmonary diseases है rather than lymphadenopathy, peripheral lymph node or associated mediastinal mass without airway compression. इसके अलावा कुछ भी है that comes under the severe disease. So before starting the treatment, we have to do pre-treatment evaluation. उसके अंदर क्या करते हैं? क्लिनिकल इवेल्युएशन करते हैं, हाइट वेट है, हिस्ट्री, फिजिकल एग्जामिनेशन, लैबोरेटरी इवेल्युएशन के अंदर HIV टेस्टिंग, ब्लड शुगर, कंप्लीट ब्लड काउंट, लिवर फंक्शन टेस्ट, thyroid, urinary examination, electrolytes are very important, sodium, potassium, magnesium and calcium, urine pregnancy test, chest X-ray and ECG. So basically ये before starting the DRTB treatment, you have to do this laboratory, at least this laboratory results are available, then you can plan to start the DRTB. ये ड्रग क्लासिफिकेशन है DRTB का, ग्रुप ए, ग्रुप बी, ग्रुप सी है. ग्रुप ए के अंदर जैसे लीवोफ्लॉक्सासिन है, मैप्सी है, बिडाक्विलिन, लिनोजुलिड, ये ड्रग्स हैं. ग्रुप बी के अंदर क्लोफासाइक्लो है. ग्रुप सी के अंदर इथम्ब्यूटोल, डेलामिनेट, पायरेजिनामाइड, मीरोपिनेम, एम्बिपिनेम, सिलास्टिन, एमिकासिन, एथियोनामाइड एंड पैरासिटामोल. तो बेसिकली DRTB के लिए हमें रेजिमेंट क्या बनाना है? ये फर्स्ट प्रेफरेंस है, ड्रग्स कभी वो यूज नहीं हुई है, DST में सेंसिटिविटी है, या ड्रग्स यूज नहीं हुई है, DST रियल्स अवेटेड है. थर्ड प्रेफरेंस है ड्रग यूज DST सो सेंसिटिविटी, एंड फोर्थ प्रेफरेंस इज ड्रग यूज DST नॉट अवेलेबल, एंड ड्रग नॉट यूज किसी भी उसमें ये DST रेजिस्टेंस आता है, यू कैन नॉट स्टार्ट दिस टाइप ऑफ ड्रग. रिप्लेसमेंट सीक्वेंस जो हम ग्रुप सी से लेते हैं, उसमें रिप्लेसमेंट सीक्वेंस में जो फर्स्ट ड्रग है वो हम डेलामिनेट, अमीकासिन, थर्ड पैराजिनामाइड, इथ्योनामाइड, पास, इथम्ब्यूटोल एंड पेनिप्स लेते हैं. जब हम ड्रग रेजिमेंट बताएंगे यदि किसी ड्रग्स में इफ वन ड्रग नीड टू बी रिप्लेस फ्रॉम आइदर ग्रुप ए, ग्रुप बी, तो ग्रुप सी की पहली ड्रग हम ऐड करेंगे डेलामिनेट. या दो ड्रग नीडेड है हमें ग्रुप ए, ग्रुप बी में दो ड्रग्स नहीं हम यूज कर पा रहे, तो हम दो ड्रग लेंगे डेलामिनेट एंड अमीकासिन. If 3 or more drugs from group A and group B need, then add 3 groups from group C, delaminid, amikacin, pyrazine. Right now जो bedaquiline है that is recommended for children more than 15 year and greater than 15 kg of body weight. Delaminid है recommended for any all age groups, but the criteria is the weight should be at least 10 kg or above. तो जो रेजिमेंट रहेगा हमारा 5 kg एंड 15 kg से above में, वहां पे तो हम bedaquiline यूज कर सकते हैं because that is recommended by the NTP. बट जहां पे 5 ईयर से कम है और 10 kg से ज्यादा वेट है, तो वहां डेलामिनेट यूज कर सकते हैं. ऑल ओरल में इंजेक्टेबल बेस्ड शॉर्ट रल रेजिमेंट यूज करेंगे बिकॉज बेडाकुलिन यहाँ पे हम यूज नहीं कर सकते हैं. बट यदि 5 ईयर से कम है और 10 kg से भी कम है तो ओनली इंजेक्टेबल बेस्ड रेजिमेंट यू कैन यूज. तो टीबी ट्रीटमेंट रेजिमेंट में क्या है? यदि न्यू केसेज है तो एज वी ऑलरेडी डिस्कस, इफ आइसोनाइजेड रेजिस्टेंस है तो 6 मंथ ऑफ लीवोफ्लॉक्सासिन, मॉक्सी, REZ एक्सटेंडेड टू 9 to 12 मंथ है. DRTB के अंदर हम नॉन सीवियर DRTB है या सीवियर DRTB है, यदि हमें शॉर्टर रेजिमेंट चलाना है तो 4 to 6 मंथ ऑफ बेडाकुलिन, 6 मंथ ऑफ लीवोफ्लॉक्सासिन, क्लोफाजमीन, पायराजिनामाइड, इथियोनामाइड, हाइड्रोज, INH, इथम्ब्यूटोल, एंड in CP 5 month of levofloxacin, clofazimine, pyrazinamide and thioamide. In this case particularly ये चाइल्ड की एज 5 ईयर से कम है you cannot give bedaquiline. तो bedaquiline जो है वो that is replaced by the amikacin basically, because shorter regimen में you cannot add the delaminate. यदि all over longer regimen है जहाँ पे जो the regimen we have discussed 8 to 20 month of bedaquiline, 6 to 8 month of the levofloxacin, moxifloxacin, linezolid, clofazimine, cycloserine, जहाँ पे उसकी एज 5 ईयर से कम है तो उसमें वी कैन ऐड द बेडाकुलिन इज रिप्लेस्ड बाय द डेलामिनेट. बट डेलामिनेट के लिए वेट एटलीस्ट जो है वो 10 केजी से ज्यादा होना चाहिए. वेट 10 केजी से कम है देन यू कैन ओनली ऐड द अमीकासिन. So initiation of ART in PLHIV, your patient detail है ART should be started as soon as possible with the 2 week of initiation TB treatment regardless of CD4 count among PLHIV. ये TB meningitis है then you can initiate the treatment within 8 weeks. Second is जो अभी regimen है that is DTG based regimen है, dolutegravir based regimen है. Double the dose of dolutegravir. Dolutegravir will be need to remain twice daily for 2 weeks. जब हमारा टीबी ट्रीटमेंट ये कंप्लीट भी होता है उसके बाद भी हम 2 वीक चलाते हैं. लोपिनावीर रिटोनावीर बेस्ड रेजिमेन है. यदि हम इसके साथ में टीबी ड्रग्स चला रहे हैं तो वी हैव टू सुपर बूस्टिंग द लोपिनावीर एंड रिटोमेनावीर रेजिमेन बाय 1:1. ये फेवरेंज बेस्ड रेजिमेन में कोई मॉडिफिकेशन की जरूरत नहीं है. या डोल्टोग्राविर और लोपिनावीर रिटोनावीर चला रहे हैं तो डोल्टोग्राविर की डोज डबल करेंगे 50 मिलीग्राम ट्वाइस डेली एंड सुपर बूस्टिंग द लोपिनावीर एंड रिटोनावीर रेजिमेन. तो टीबी इन CLHIV में कंफर्म HIV इन्फेक्शन है. इफ द एज ऑफ द चाइल्ड इज below 6 years, body weight is less than 20 kg, then the regimen is abacavir, lamivudine and dolutegravir. Right now dolutegravir is also approved below the age of 6 year and body weight of less than 20 kg. If age is 6 to 10 year and body weight is 20 to 30 kg, then the regimen is same ALD, abacavir, lamivudine and dolutegravir. If age is greater than 10 year and body weight is greater than 30 kg, then the regimen is tenofovir, lamivudine and dolutegravir. So this is a very important slide regarding the BCG vaccination in neonates. So BCG vaccination reduces the risk of disseminated and meningeal TB. As you all know, near about 80 to 85% you can reduce by giving the BCG vaccine at the time of the birth. जो हमारा इंडिया के अंदर जो प्रोग्राम चलता है वैक्सीनेशन का उसके अंदर भी नेशनल इम्यूनाइजेशन शेड्यूल के अंदर भी BCG you have to give the BCG vaccination at the time of the birth. WHO की रिकमेंडेशन है न्यूनेट born to mother of unknown HIV status should be vaccination as the benefit of BCG vaccination is more than the risk. Neonate of unknown HIV status born to HIV infected mother should be vaccinated if they have no clinical evidence others of the HIV infection. Third है neonate with confirmed है ये HIV virology testing में, then BCG vaccination should be delayed until ART has been started and the infant confirmed to be immunologically stable at least CD4 count greater than 25% हो. NACO के accordingly BCG vaccination at birth of all HIV exposed baby. If BCG not given at birth, it should be given to symptomatic older infant and children, not be given to symptomatic children. Regarding the TB preventive therapy nowadays, this is a very important thing. In the TB preventive therapy, that decreases the developmental of the TB disease by near about 60% and up to 90% among the people living with HIV. Effective implementation of the TPT has shown to reduce the annual incidence of the active TB disease by 8.3%. RCT trial involving PLHIV in 2009 showed IPT reduced the overall risk of the TB by 33% and the preventive efficacy is 64% if they have TST positive. तो इसके अंदर टारगेटेड पॉपुलेशन है यदि HIV पॉजिटिव है तो एडल्ट एंड चिल्ड्रन ग्रेटर देन 12 मंथ ऑफ एज एंड इन्फेंट बिलो 12 मंथ विद HIV इन कॉन्टेक्ट विद एक्टिव TB डिसीज. तो TPT in all ruling out active TB disease. मतलब you have to give the TPT in all children of HIV positive on ART, but only in the case of the infant who is below 12 month of the age and have contact with the TB cases, you can consider only then in these infants. Household contact below 5 years of the pulmonary TB patient, you have to give the TPT therapy only to rule out the TB disease. But above the 5 years of the age of pulmonary TB patient, TPT therapy among TBI positive, TB infection positive cases में recommended है above 5 year of the age. First you have to test, then treat these type of the cases. Then the next extended target population है on immunosuppression therapy है, having silicosis है, anti-TNF treatment है, dialysis है, and prepare for organ hematologically transplantation. TPT after ruling out the TB disease. TPT therapy में all household contact of pulmonary TB cases. Among the CLHIV group, children greater than 1 year in respect of the TB exposure and children below 1 year with TB exposure. Ask for the TB symptoms. If TB symptoms is present, investigate for TB. Treat for TB. If no TB symptoms is present, then if the child age is below 5 year, initiate TB preventive therapy. Age is above 5 year, between 5 to 18 year, it is better to test first the TB infection, then the treat the TB infection. TPT regime recommended by for DSTB के लिए recommended है. Rifampicin is not widely available under NTP, so currently recommendation is continue with 6H regimen and gradually shift to 3HP once rifampicin is incorporated well under the program. Contraindication है तो protease inhibitor and NNRTI. You can use with efavirenz and dolutegravir and datigravir patient. So in the drug sensitive cases, 6 months of INH is recommended, 5 mg per kg per day if the age is greater than 10 year, and if age is less than 10 year, then the dose is 10 mg per kg per day. In the case of 3HP regimen, it is given weekly. So regarding INH plus rifampicin, that comes under 150 and 150 mg, and 10 to 15 2 tablet, 16 to 23 3, 34 to 30 to 34 4, 31 to 34 5, and greater than 34 kg 5 kg. Risk of TB incidence reduced 90% after TPT therapy. Levofloxacin 100 mg dispersible tablet available for children from 1 to 14 year age. 4 hours should only be used in the limited geographical population for evidence generation. So in the case of INH resistance, 4 hours is recommended. If the age of the child is below 10 years, then if 15 mg per kg per day, and if age is greater than 10 years, then the dose is 10 mg per kg per day. And 6 months of levofloxacin in rifampicin resistance and FQ sensitive patient. If the age is less than 15 years, the dose is 15 to 20 mg per kg per day. If age is greater than 15 years and weight is less than 45 kg, 50 mg per day, and if the weight is greater than 45 kg, then 1 gram per day. And in the age group of 5 to 34 kg, you can give as per the chart recommended by the program. What are the contraindication of the TPT? If absolute contraindication is active TPT, acute chronic hepatitis, concurrent use of other hepatotoxic drugs, signs and symptoms of the peripheral neuropathy, just like a burning sensation, persistent tingling and numbness, contact with DRTB cases, PLHIV who has completed DRTB treatment, and allergy of unknown hypersensitivity of any drug. So pyridoxine is also a adjuvant drug which is added in the group of the children who are malnourished, HIV infected, have renal failure, diabetes, pregnant or breastfeeding females, and chronic alcohol dependence, and in the adult group. So the dose of the pyridoxine in prophylactic dose is 10 mg per kg in children. The dose is near about 0.5 mg per kg per day. So in the children, it is recommended near about 10 mg per kg in the children, 25 mg in adult, and 15 mg per kg in adult PLHIV. And therapeutic dose in case of the peripheral neuropathy, tingling sensation, burning sensation. So in this particular group, the therapeutic dose is near about 3 to 5 mg per kg per day. So it comes near about 100 to 200 mg per day. Pyridoxine supplement. Thank you very much.
Thank you, sir. थैंक यू सर इतना एग्जॉस्टिव प्रेजेंटेशन देने के लिए. तो आई थिंक हम लोगों का काम बहुत आसान हो गया है, क्योंकि एक ही जगह हमारे पास एक रिसोर्स बन गया है वेयर वी कैन गो बैक फॉर सो मेनी क्वेश्चंस, क्योंकि सर ने गाइडलाइंस भी कवर कर ली और आई एम श्योर जो डाउट्स डॉक्टर पूजा को थे, चैलेंजेस, वो भी सर ने अच्छे से डिस्कस किए. उससे स्कूल के आंसर्स बता देते हैं।
आई एम श्योर सर की जो प्रेजेंटेशन थी उसमें आप लोगों को आंसर्स मिल ही गए होंगे। तो हमारा फर्स्ट क्वेश्चन था, चिल्ड्रन लिविंग विद HIV जिनकी उम्र 10 साल से ज्यादा और वजन 30 किलो से ज्यादा है, तो नैको गाइडलाइन उनको कौन सा ART रेजीम प्रिस्क्राइब करती है, रेकमेंड करती है? तो इसमें करेक्ट आंसर है ऑप्शन सी, टिनोकोविर, लैमिविडिन और डोल्टाग्राविर। क्वेश्चन 2 था, IPT 12 महीने से कम उम्र के बच्चों में IPT कब रिकमेंडेड है? जो HIV एक्सपोज्ड बच्चे हैं, उनका अभी कंफर्म नहीं हुआ है HIV डायग्नोसिस, बट जो बच्चे HIV एक्सपोज्ड हैं और 12 महीने से कम उम्र है, तो उनमें कौन सा ऑप्शन है जिसमें हम IPT दे सकते हैं? तो इसका ऑप्शन है, करेक्ट आंसर है ऑप्शन ए, जिन बच्चों को TB एक्सपोजर है, जिनके फैमिली में किसी को TB है और उनकी उम्र 12 महीने से कम है बच्चों की, तो उनको आप IPT दे सकते हैं जी। और इसी के साथ अभी आपको फीडबैक चैट बॉक्स में लिंक भेजा जा रहा है और आप उसमें अटेम्प्ट, उस पे आप अपना फीडबैक दे सकते हैं कि आपको सेशन कैसा लगा। और मैं आप सभी से आगे के लिए भी अनुरोध करूंगी कि हमारे ये सभी सेशंस यूट्यूब पे अपलोडेड हैं, इको प्लेटफॉर्म पे हमारे सारे सेशंस अपलोडेड होते हैं विद रिकमेंडेशंस। तो आप आगे फ्यूचर में भी इनको कभी भी रेफरेंस के लिए यूज कर सकते हैं।
क्योंकि हमारे पास आज टाइम कंस्ट्रेंट है, तो एक बस क्लोजिंग कमेंट आपसे टेक होम मैसेज लेना चाहूंगी, क्योंकि हमारे HIV के पेशेंट्स वैसे ही बच्चे वैसे ही वानरिस्ट होते हैं, तो कुछ ऐसा आप रेड फ्लैग या कुछ बताना चाहेंगे टू कीप इन माइंड इन एन OPD?
बेसिकली क्या है ना, बच्चों के अंदर एज यू ऑल नो कि दिल्ली के अंदर या NCR के अंदर अभी लास्ट जो अभी विंटर निकला है, मोस्ट ऑफ द चिल्ड्रन हैव कफ। जो भी है बच्चे वो हमेशा कफ करके ही आते हैं। तो OPD के अंदर यू हैव टू आइडेंटिफाई कि कौन सा कफ वायरल है, कौन सा बैक्टीरियल है, कौन सा TB है। ठीक है, क्योंकि मोस्टली जो बच्चे ड्यू टू पॉल्यूशन, ड्यू टू वायरल डिसीज, ड्यू टू इन्फ्लुएंजा, या जो बच्चे स्कूल में जाते हैं वहां पर कांटेक्ट में आते हैं दूसरे बच्चों को, तो वो सिर्फ एक कफ की तरीके से प्रेजेंट करते हैं। तो सबसे पहले रेड फ्लैग साइंस जनरली बच्चों में आइडेंटिफाई करने का ये है कि यदि बच्चे के अंदर कफ के अलावा उसको वेट लॉस हो रहा है या बच्चा वेट नहीं गेन कर रहा है। सेकेंड थिंग इज दैट कि उसका जो कफ है, इंस्पाइट ऑफ गिविंग द मेडिकेशन, आपने कई डॉक्टर्स बच्चे ने को दिखा चुका है, उसके बाद भी उसका जो है ना कफ इंप्रूव नहीं हो रहा है और बच्चे का जो है वेट नहीं इंप्रूव हो रहा है। और थर्ड थिंग इज दैट कि फैमिली में किसी को भी TB का इन्फेक्शन है। तो दीज 3 पॉइंट्स आर वेरी इंपॉर्टेंट, कि ये आपके लिए एक रेड फ्लैग साइन है टू आइडेंटिफाई कि ये बच्चा जो है कहीं TB का केस तो नहीं है। क्योंकि ये 3 क्लिनिकली ओनली यू कैन असिस्ट द चिल्ड्रन बाय द क्लिनिकल जजमेंट। तो ये क्लिनिकल बेसिस पे आपको ये 3 पॉइंट पकड़ने कि बच्चे को वेट लॉस हो रहा है, बच्चे का सिग्निफिकेंट, जैसा मैंने डिस्कस किया था, बच्चे को फीवर हो रहा है, सारी आपने इन्वेस्टिगेशन करा ली, इन स्पाइट ऑफ दैट बच्चे में फीवर, हमेशा यू हैव टू डॉक्यूमेंट द फीवर, कि बच्चे को इवनिंग आइज फीवर है तो हमेशा चेक करो उसको, तो एटलीस्ट दिन में 2-3 बार उसके पेरेंट्स चेक कर रहे हैं, टेम्परेचर चार्ट बना रहे हैं और वहां आपको लग रहा है कि बच्चे को इवनिंग में फीवर हो रहा है, फीवर है, वेट लॉस है, बच्चे को कफ है, तो ये एक रेड फ्लैग साइन है कि जहां से आप आइडेंटिफाई कर सकते हो कि बच्चे को TB का इन्फेक्शन तो नहीं है। और कॉन्टेक्ट हिस्ट्री एक बहुत इंपॉर्टेंट है, कि कॉन्टेक्ट हिस्ट्री उसकी फैमिली में किसी को भी है तो एटलीस्ट जो है आप उसको TB डिसीज को रूल आउट कराओ, या TB डिसीज आप रूल आउट हो जाती है तो यू कैन स्टार्ट द IPT थेरेपी आल्सो to prevent this children into the TB infection, TB disease.
थैंक यू सर, थैंक यू। आपने बिल्कुल ही वैल्यूएबल पॉइंट्स बोले हैं, जो कि आई एम श्योर आपकी बात और आपकी जो लेक्चर है वो हमारी यूट्यूब चैनल में रहेगा सेव। तो आई वुड रिक्वेस्ट कि आप लोग प्लीज, एक बार में इतना सब कुछ इम्बाइब करना पॉसिबल नहीं होता है, सो एज एंड व्हेन जब आपको केसेस आए आप प्लीज इस लेक्चर को दोबारा विजिट करें और सीखें इससे। डॉक्टर पूजा, आई होप आपका फ्रूटफुल रहा केस प्रेजेंटेशन और
वेरी एजुकेटिव, और मुझे पता चला कि हाँ, हमें बच्चों के केसेस में क्या क्या ध्यान रखना है। स्टिल अभी भी चैलेंजेस बहुत है, बट वी आर ट्राइंग टू ओवरकम दैट.
Yes, it's a journey.
It's a journey.
Yeah. Thank you.
Thank you.
So with that, I would like to thank our expert, Dr. Alok sir. Thank you, sir, for joining us.
Thank you,
and
Dr.
giving us your
Ananya,
valuable time.
Thank you very much. Dr.
थैंक यू
Jyoti.
सर। मैं आपको बहुत ही धन्यवाद देना चाहती हूँ कि आपने सभी गाइडलाइंस, चाहे वो ART हो, ड्रग सेंसिटिव टीबी हो या ड्रग रेजिस्टेंट टीबी हो, सभी को आपने इसमें कवर अप किया है और हमारे पार्टिसिपेंट्स को उसके लिए एजुकेट करने की कोशिश करी है। एंड उसके लिए इसमें एक छोटा सा पॉइंट मैं ऐड करना चाहती हूँ, जो जैसे कि CLHIV में हमारी गाइडलाइंस कहती है कि कॉफ ऑफ एनी ड्यूरेशन इज कंसिडर्ड एज प्रिजम्पटिव टीबी केस, लेकिन जैसे कि सर ने उसमें एनलाइटनमेंट हमको दिया है कि उसके सिर्फ आप कफ पे नहीं देखें, कफ के साथ बाकी सब चीजों को भी देखें कि बच्चे के अंदर है कि नहीं है, ताकि वो आपको ज्यादा सपोर्ट प्रोवाइड करेंगे फॉर मेकिंग अ करेक्ट डायग्नोसिस। थैंक यू सो मच सर। और मैं डॉक्टर पूजा
Thank
को
you.
भी थैंक यू कहना चाहूंगी कि वो इतना अच्छा केस लेकर आई। आई एम श्योर कि हमारे यहाँ पे बच्चों में डायग्नोसिस करना, क्योंकि सैंपल लेना भी उसमें बहुत डिफिकल्ट होता है और डायग्नोसिस बनाना, ये सब डिफिकल्टीज रहती हैं। तो आज आप वो केस लेकर आए, तो इस करके हमारे पार्टिसिपेंट्स को भी डेफिनेटली इसके बारे में जरूर ज्ञान मिला होगा कि वो आगे कैसे बच्चों को डायग्नोज करें और ट्रीट करें। And I thank Dr. Ananya for moderating this session in such a nice way. हमेशा से ही मैम इतने अच्छे से सेशन को मॉडरेट करती हैं कि कुछ कहने को रह नहीं जाता है फिर। एंड आई थैंक ऑल द पार्टिसिपेंट्स। आप लोगों की अटेंडेंस की वजह से ही लगता है कि सेशन सक्सेसफुल है, ताकि क्योंकि ये जो नॉलेज हम दे रहे हैं वो वहां तक पहुंच रही है, और आई एम श्योर कि यू विल बी बेनिफिटेड विद दिस नॉलेज। And at last, I'll thank my team member, Mr. Rakesh, who is providing us the support. Thank you very much.
Thank you.
Thank you.
Thank you, Dr. Ananya, Dr. Pooja, and Dr. Jyoti. Once again.